Dear student, we hope that with the grace of Almighty Allah, you are well. After a short gap, we are again in the class. Today, we will discuss diarrhea according to IMCA protocol. Diarrhea. Let us see first what is diarrhea. Diarrhea is defined as passage of loose stool 3 or more times a day. Globally, near about 4 million of child dies a year. Near about it is the second cause of child death after pneumonia. Most of the diarrhea occurs in between 6 months to 2 years, and rotaviral diarrhea prevalent in between age 6 months to 12 months. It is in the second half of infancy. Regarding the etiology of diarrhea, it is caused by different types of viruses, bacteria, parasites and others. Among the viruses, rotavirus is the most common cause, and other virus also enterovirus. Regarding the bacteria, most common bacteria are E. coli, Shigella, Vibrio cholera, Salmonella, Campylobacter, etc. And regarding the parasites, Enterohistolytica, Giardia lamblia, Hellman's, these are the cause. There are also some non-pathological cause of diarrhea also. Regarding the pathophysiology of diarrhea, we can say, as we know, there is a balance between secretion and absorption in the GI tract. When there is any imbalance between that secretion and absorption occurs, the diarrhea results. Normally, secretion from the intestine is less than absorption. That is, absorption is more, secretion is less. When this abnormality occurs, that is, secretion, any bidirectional movement of fluid hampers, fluid accumulates in the intestine and comes down in the large intestine, and the large intestine capacity of absorption is less, so fluid, appropriate amount of fluid is not absorbed in the large intestine, and fluid comes out as diarrhea. This abnormality may occur by 2 mechanisms, one of which is more common in the secretory mechanism. Secretory mechanism is that due to different types of organisms, as for example E. coli, Vibrio cholera, etc., when ingested, they passes through the stomach and comes to the large in the intestine, where they colonizes, and after colonization they produce some enterotoxins. These enterotoxins then activate certain intracellular mediators like cyclic MP, cyclic GMP, calcium ion, etc., causing activation of these mediators, and there, as a result, there is increased secretion of the chloride ion in the intestinal lumen and inhibition of the sodium chloride absorption from the lumen. So there is in excess amount of fluid in the small intestine, which then goes back to the large intestine. On the other hand, in the osmotic mechanism, certain osmotically active substances which are partially digested from the small intestine goes to the large intestine. These partially digested particles, when goes to the large intestine, in the large intestine several types of flora are there. This flora breaks down the partially digested product into smaller fragments and increasing the osmotic load in the lumen of the large intestine, and from there, by the osmotic action, fluid from the extracellular space comes to the large intestine lumen, and there is bulk of fluid in the large intestine lumen. This then comes out as a loose motion. Here, different types of viruses and bacteria causes injury to the small intestine. There is the brush border of the small intestine, and enterocytes are destroyed temporarily by these different types of viruses, bacteria, and organisms. As a result, the enterocyte sheds out, and proper absorption cannot be taken place, so that there is increased secretion. On the other hand, less absorption in the small intestine. So these are the in short pathophysiology of the diarrhea. Now let us see what will be the pathophysiological consequences of diarrhea. Pathophysiological consequence of diarrhea is first of all loss of water from the body. These water losses from the causing fluid loss from the body, causing the hypovolemia. This hypovolemia causing the decreased renal perfusion pressure, and due to the decreased renal perfusion pressure, there is oliguria, even then is anuria, or even renal failure may occur. Due to the decreased pressure, there heart has to work hard, and there may be even heart failure. There may be also hemoconsumption also. Due to the loss of electrolytes from the body, especially potassium, causing the hypokalemia and its different types of untowards effect to the body. There is also hyponatremia, and due to the loss of bicarbonate, metabolic acidosis. All these losses causes the bad effect of diarrhea in the body. Another bad effect is loss of zinc from the body. Due to the loss of zinc, there is a delay in the recovery from the diarrheal process, and also loss of immunity, because zinc causes the immunity, increases the immunity. And due to the loss of digestive materials and food nutrient from the body for a long period, as for example in the persistent diarrhea, there is malnutrition. So these are the four pathophysiological consequences of diarrhea, namely due to the loss of water, there is hypovolemia, anuria, oliguria, or renal failure, heart failure, or hypokalemia, hyponatremia, metabolic acidosis, zinc loss, and from long-standing cases there is malnutrition. Now let us see what will be how we'll manage the case of diarrhea. all the children suffering from diarrhea may have following three conditions: acute watery diarrhea, that means diarrhea starts acutely but it do not persist more than 14 days. Dysentery, where the diarrhea starts acutely, not persisting 14 days, and containing visual blood in the stool. We can elaborate this definition of dysentery as passage of loose stool with visual blood in the stool associated with cramping, abdominal pain and tenesmus. This definition is more appropriate for our medical students. And persistent diarrhea. Persistent diarrhea, the diarrhea starts acutely but it persists 14 days or more. So we can classify diarrhea as acute watery diarrhea, dysentery and persistent diarrhea. Persistent diarrhea is again classified as persistent diarrhea and severe persistent diarrhea. When persistent diarrhea associates with any source of dehydration, we call it severe persistent diarrhea. Now, let us say how we will manage dehydration. For the management of dehydration, first of all, we should correct dehydration. For the management of diarrhea, first of all, we should correct dehydration. And next steps are diagnosis for the cause of diarrhea. And after diagnosis, we should give drugs, including zinc, and we will give dietary therapy, then appropriate diet during the diarrhea. And finally, we will discuss about the prevention, how we will prevent diarrhea. So let us see how we will correct dehydration first of all. For the correction of dehydration, we should classify dehydration at first. Dehydration is classified according to following four important signs. First sign is the sunken eye. We should look for the sunken eye. Every dehydration child has some sorts of sunken eyes. Then about the general condition of the baby, whether the baby is looking well, playful or not, whether the baby is very much irritable or restless, or baby is unconscious or very much lethargic. After that, what will be the next sign is the baby's reaction to food or drink when offered. If the baby do not want to take food or drink, or takes after encouragement, we can categorize that no sign of dehydration. On the other hand, if the baby drinks eagerly or the baby wants more and more, we can categorize as some dehydration. And if the baby do not takes food or drinks, or baby is very lethargic, he is not able to take drinks, we will categorize that severe dehydration. And finally, about the skin elasticity examination. It is done by skin pinch. We will show it by video how skin pinch is elicited. For the skin pinch examination, we should first look at the site. Site is the in between umbilicus and lateral abdominal wall. So place will be in between between the lateral abdominal wall and umbilicus. We'll use our thumb and radial border of the index finger. We'll put the full thickness of the skin, and skin fold should be vertical, not horizontal. And we will pull out the skin for a while, not more than 1 second, and we will keep it away. If the skin fold goes immediately, we will say no signs of dehydration. If it takes less than 2 seconds, slowly but less than 2 seconds, we will categorize it as a some dehydration. And if it takes longer than 2 seconds, we will categorize as severe dehydration. By this way, using this 4 sign, we categorize the dehydration as some dehydration and no sign of dehydration, some sign of dehydration, and severe dehydration. By using these 4 signs, if out of 4 signs any 2 of the signs are present, we will put the diagnosis on that group. Suppose if the baby is irritable and drinks eagerly, so there are 2 signs out of 4 signs, so the baby will be in the some dehydration. On the other hand, as for example, in case of severe dehydration, if the baby is not able to drink and skin pains goes back very slowly, there are 2 signs out of 4 signs, the baby will be in the severe dehydration. So in this way we classify dehydration. So dehydrations are 3 types: some no sign of dehydration, some dehydration, and severe dehydration. Now let us see how we will correct dehydration. For the correction of dehydration, there are treatment plan by WHO. For the no sign of dehydration, we will put the baby on WHO treatment plan A. For the some dehydration, we will put the baby on the WHO treatment plan B, and for the severe dehydration, we will put the baby on WHO treatment plan C. First of all, we see the correction of dehydration in the WHO plan A for the no sign of dehydration. Here, the dehydration is there is sunken eye, or baby drinks normally or by encouragement. Here, our treatment plan is to give more fluid more food and referral knowledge. That is, we will give oat saline when the baby asks for drinks to correct the existing fluid loss. We will give oat saline during each purging. For each purging, we will give oat saline near about 50 ml. 50 ml equivalents to 10 spoon, because 1 spoon is equivalent to 5 ml. So accordingly, per loose stool we will give about 50 ml. But if the baby asks more, then we will give more fluid to the baby. And other foods, homemade food, according to the age of the baby, we will offer. Food should be which is very much convenient and easily available to the family. Suppose homemade food, bhater maar, chira pani, yogurt, cooked rice, etc. It can be given. But following foods, as for example, soft drinks, fruit juice, sweetened tea or coffee, etc., should not be given. Because if these are given, there is chance of hypernatremia and osmotic diarrhea. So these drinks should be avoided. And referral knowledge, we mean that we will give idea to the mother that you will go to the home with oat saline and keep it to the baby. But if in the house you will see baby becomes very much sicker, if there is blood in the stool, or the baby is not getting well within 2 days, or baby become very much baby causing repeated vomiting or lethargy, then you will come back immediately to the doctor or caregiver. So this is the referral knowledge. So with this referral knowledge, we will send the baby to the house with the mother. So these three important things is for the correction of dehydration according to treatment plan A. I repeat, give more fluid, more food, and referral knowledge. Now let us see how we will correct some dehydration according to treatment plan B. Some dehydration is corrected by oral rehydration saline, oat saline. It is given orally, and fluid is about 75 ml per kg body weight, and time 4 hours. So we will put the baby in ORT corner. ORT corner is a separate room. It is nearer to the doctor's room. It is supervised by the trained nurse. Here, trained nurse will teach the mother how oat saline will be given. It will be given by a spoon, gradually and frequently. If the child vomits, we will wait for 10 minutes and again we will give. And in this way, within 4 hours, we will give 75 ml of oat saline, 75 ml per kg body weight oat saline to the baby. As for example, if the child's weight is about 10 kg, we will give 10 into 75, that means 750 ml of oat saline. So this 750 ml of oat saline we will give within 4 hours gradually, and after 4 hours we will assess the condition of the baby. If the baby's condition improves, that means baby then will be put on the treatment plan A. That is, we will send the baby to the home with the previous advice. After 4 hours, if we see that the baby is not improving, rather the baby is deteriorating, then we will put the baby on the treatment plan C, WC treatment plan C. Here in the treatment plan C, for the correction of severe dehydration, baby is admitted in the hospital. And after admission, we will start IV fluid for the correction of dehydration, for the correction of severe dehydration. Fluid is either chloride saline or Ringer's lactate saline. And amount of fluid should be 100 ml per kg body weight. As for example, if the baby's weight is about 10 kg, amount of fluid will be 10 into 100, that means 1000 ml. This 1000 ml fluid we will give to the baby. And procedure how we will give the fluid, it depends on the age of the child. If the age of the child is in between 1 month to 12 months, then we will correct the dehydration within 6 hours. And if the age of the child is in between after the if the child age of the child is more than 1 year, then we will correct the dehydration by 3 hours. Out of that 6 hours, in case of child below 12 months, it is given by 2 rations. In first half, we will give 30%, that is 30 ml per kg body weight. And next 70%, that is 70 ml per kg body weight, will be given by 5 hours. So total 6 hours will correct the dehydration, severe dehydration for the baby whose age is less than 12 months. And for the baby whose age is more than 12 months, we will correct by 3 hours. Here in the first half an hour, that is first 30 minutes, we will give 30%, 30 ml per kg body weight. And for the rest 70%, that is 70 ml per kg body weight, we will give within next 2.5 hours. So total correction hour will be 3 hours. First half an hour 30%, and next 70% by 2.5 hours. In this way, we will correct severe dehydration. After 1 to 2 hours, we will assess the status of dehydration. If the patient is not improving, we will give the IV fluid more rapidly. And if the baby can drinks oat saline in the same time, we will give oat saline orally with the dose of 5 ml per kg per hour. And after that, we assess the condition of the baby. For the child whose age is less than 1 year, we will assess after 6 hours, and for older children, we will assess after 3 hours. So after 3 hours or after 6 hours, if the condition of the baby improves, then we will put the baby according to the classification of the dehydration status. Suppose if the baby improves, then we will put the baby to some dehydration. Here again we will give orally oat saline, and if more improves, then we will put the baby in treatment plan A, and we will refer the baby to the home with home advice. In this way, we correct severe dehydration. So, after correction of severe dehydration, in the same time, we will find out the causes of diarrhea. Our next step is to diagnose the cause of diarrhea. For the diagnosis, important tool is the stool examination. First and most important tool is the examination of the stool, and next is the blood test, especially for total count of WBC, serum electrolyte. Other tests, as for example, ultrasonogram, chest X-ray abdomen in the erect posture, or serum creatinine, blood urea, and other investigation. If the complication arises, usually this investigation do not needs for the diagnosis or management of the diarrhea. That is, for the diagnosis of the diarrhea, our stool examination is important. Next is the examination of the blood for CBC and serum electrolyte. Stool examination should be done in details. Suppose stool routine examination, stool microscopic examination, stool reducing substance, stool reducing substance, stool culture. All this should be done, and after diagnosis, we should give the proper treatment according to diagnosis. Suppose drugs should be given according to the cause of the diarrhea. As for example, if Shigella is found, so appropriate sensitive drugs, ciprofloxacin is given. If that is antihistolytica is found, then appropriate drugs, as for example, metronidazole is given. If Vibrio cholerae is found, then tetracycline or erythromycin given according to the age. That is, for older children, tetracycline, and for the younger children below 2 years, erythromycin is given. In this way, after diagnosis, we will treat the diarrhea according to the cause. Next drug is zinc. Zinc should be given in every case of the diarrhea. Dose of the zinc is near about 2 mg per kg body weight. And after giving the drugs, proper diet should be given according to age. For breastfed mother, frequent breastfeeding should be given, and mother should encourage to take sufficient amount of fluid so that sufficient milk secretion occurs, and baby can get enough breast milk. So this is the drug treatment. And if there is any reducing substance in the stool, that is osmotic diarrhea, then appropriate diet should be given. So lactose-free milk can be given in case of lactose intolerance, and diet should be modified with lactose-free milk if there is diarrhea due to the lactose intolerance. And finally, we should give advice to the mother how diarrhea can be prevented. For the prevention, we will discuss the mother about the proper hand washing, because this diarrhea occurs by the organisms which is due to the orophycal route. It means if proper hand washing occurs, usually diarrhea can be prevented. So proper hand washing is important. Then proper disposal of the excreta. Safe drinking water is needed. Food should be freshly prepared, and food should be covered. Mother also will give nutritious food to the baby. In this way, diarrhea can be prevented. Now, let us see about the dysentery. Treatment of dysentery depends on the organism. If it is in case Shigella, then ciprofloxacin. If Salmonella, ciprofloxacin or other sensitive drugs can be given for the dysentery. And for the persistent diarrhea, frequent feeding should be given. For the persistent diarrhea, feeding should be appropriate, and vitamins and minerals should be given. Vitamins, suppose vitamin A, folic acid should be given, and minerals, suppose zinc, magnesium, iron, etc. should be given for the persistent diarrhea. So diarrhea, for the management of diarrhea, we will correct dehydration, we will diagnose the causes of the diarrhea, we will give the appropriate drugs, we will give zinc, and we will modify the diet if needed by lactose-free milk, and finally we will give advice how diarrhea can be prevented. So thank you for the class.